So it's 4:30. Thanks everybody for joining the call. Happy to call our meeting to order. And Jeffrey, if you would, please take the roll.
Bishop Badger,
Present.
Ron Bennett,
Present.
Scott Paluski,
Here.
Ron Chapin,
Here.
John Dandies,
Here.
Darby Fishkin,
Here.
Katie Grimm,
I'm here.
Sharon Hansen,
Here.
Mike Hoffert,
Here.
Jim Lewicki,
Here.
Chris O'Brien,
Here.
Bill Pauley, Jen Persico,
Here.
Jack Quinn. Yeah,
He's there. He's coming back.
he'll be coming back. Gino Rusi and Mike Seaman.
Here.
John, would
So-
you like me to include the executives?
No, we don't need
Not for the purposes of the roll call, Jeffrey. Thank you.
Thank you.
But thanks everybody for joining the call. And meeting is called to order. We'll dispense with the reading of the minutes unless there are any additions, deletions, or corrections. Are there any? Seeing none, thank you. We'll consider them approved and go right to the, we got a very packed agenda today, ladies and gentlemen, including an executive session. So we're going to move as expeditiously as possible. But our first presentation is by Cindy Bass with regard to diversity and inclusion. So Cindy, if you would take it away, or Andy, if you have any, Tom or Andy, any introductory comments before Cindy does the presentation?
Yeah, just very quickly, Cindy's been doing a great job. And obviously Andy's been directly involved, making sure that as we launch our diversity and equity and inclusion efforts, that we're very inclusive of middle level management and our union partners. They've been very involved in the process. She'll go through the pillars of what we've been focusing on, but I think as a result, we're kind of leading the way. Cindy's been getting a lot of phone calls from others in the community asking her about hearing about the efforts that we're doing here and asking a lot of questions. So Cindy's going to go through today kind of what we've been working on. And then I would like to mention, I know we've been trying to get a board training scheduled, and obviously COVID has made that very challenging. So John and I talked earlier today, and we're going to have a board training session planned for January before the board meeting. So hopefully we'll be able to do that and have a location off-site that we can socially distance. So hopefully we'll be in a place to do that. If we're not, we'll have to do an audible again. But that's our plan at this point, to have the board trained at that before that meeting. So with that, Andy, do you have any other comments?
No, it's been certainly a nice journey for us as an organization, and Cindy, as Tom alluded to, done a wonderful job, and I think from the work that you see that she'll present today, that our journey continues and it's worthwhile work. So with that, Cindy, if you would go ahead and start, I really appreciate it.
Okay, thank you so much, Tom and Andy, and good afternoon to everyone. I just want to say that we have had a successful year so far, and with the recent events that has been taking place in America, this has really enabled us to expand our horizons and grow and develop as a diversity office. So we're very excited for our initiatives that we have done this year and what we have forthcoming. So our next slide.
Sorry.
No, that's okay. So as Tom has mentioned, these are our diversity and inclusion strategic pillars that we have set the foundation of the diversity and inclusion program and all of our initiatives and our diversity efforts. We really strive to focus on our patient experience, which is the core of our organization, our workforce development, our community engagement, and of course, our organizational cultural proficiency, where we're continuing our education and our training and bringing awareness to the employees here in our organization. Next slide. So what we wanted to, first, I wanted to talk about our community hiring stats. And as you can see, our numbers here for our new hires. For 2020, we did hire approximately 525 employees. What we're very proud of here at ECMC is that for 2019 and 2020, we have hired, we have had the largest hiring from the Western New York zip code of 14215. So we're very proud of that, to really be out and recruiting and hiring employees from our community. So we're very proud of that, and we hope to see that number increase as we move forward. And just to mention, our ECMC 2020 MWBE utilization percentage has been 36.66%. And Andy, I'm not sure if you wanted to speak about that at all, make mention of the MWBE.
I'll just mention it briefly. We have a committee that meets on a monthly basis to review our MWBE spend. A number of years ago, we consolidated into actually into John's area, and Diane Arteri and her team have done an excellent job. And we continue to be mindful of trying to make sure that we spend dollars within our community. So thank you, Cindy.
All right, thank you. Next slide. So with our minority hiring stats, as part of the role in our program as for diversity and inclusion, we like to monitor and keep a dashboard on what we're doing here in our organization. And looking, I was looking at our stats with the city of Buffalo and the population that we have here. ECMC, if you can notice the numbers that's highlighted, we're doing very well in our cultural and with our new hires for minority. And this year was a little, the numbers did decrease a little, but we have with our hiring with the pandemic, of course that has changed, and we wasn't much hiring. However, our numbers are looking good, and we're very proud for where we are for year to date. Our next step is really to focus on retention and advancement and promotions for our minorities. And I'll speak more to that in a little bit in the presentation. Next slide.
Cindy?
Yes.
Before you continue, would everyone please put their phones on mute? It's very distracting, and I see Ron Chapin and Mike Seaman. Your names keep coming up on the screen here. So particularly if you guys could put your phones on mute, it would be very, very helpful. I'm sorry, Cindy, please continue.
Okay, thank you. So I just want to talk a little bit about our 2020 accomplishments from the Office of Diversity. This year we were recognized from Buffalo Business First for receiving the Ideal Awards. And this award is given out to organizations that promote diversity and inclusion in Western New York. And this was the first time that this award has been given out. So we're very proud as an office and organization to represent ECMC and receive this. We collaborated with Diversity University. So all of the training and education, the collaboration that we do with the training department will be under Diversity University. So we have our own logo, and we're very proud with any training that, again, in education will fall under this. This year we did introduce This Is Home, which is continued education, facilitating culture change, one conversation at a time. And I believe that this will continue in January, hopefully. And the board, you will get a chance to go through this education. This year also, ECMC was recognized as a top performer through the Human Rights Healthcare Equality Index. And this is for our LGBTQ patient and employee recognition that we just recognize as an organization that we care and that we provide service and excellent patient care to our LGBTQ population. We established the diversity and inclusion service line, which I'll show you at the end of our presentation. And we also added a program coordinator position to the Office of Diversity and Inclusion. Next slide. We have created the diversity and inclusion website on the intranet and the internet page. We just completed our diversity and employee engagement survey. The last day was on yesterday, and we have approximately 1,200 employees that completed the survey. Earlier this year, we collaborated with the wellness team, and we did a focus with diversity event, which was very successful, and our employees were able to get wellness points if they attended some of the events during this day. We established the Diversity and Inclusion Council task force teams, which I'll talk about briefly. And we have had some crucial conversation sessions, approximately 4 sessions, and we have had a little over 40 employees that has attended these sessions. And I'm going to introduce, Andy, if you could talk about the diversity engagement teams that we have done with Terraceview.
Yeah, we've, I guess several weeks ago, Tom and myself, Pam Lee and others did several sessions, town halls, if you will, over at Terraceview that were for the staff. We did them for multiple different times. It really brought out a number of different challenges that they have in terms of culture and diversity there. So we have certainly engaged our team leaders in having dialogue and conversation that's been led by Pam Lee and Cindy. We have tried to address certain things in collaboration with Karen's team with hair care products for our residents that are more from an ethnic background. And we will continue to address the diversity over at Terraceview, also in the tower, but certainly with Terraceview, with some of the dynamics that they have and challenges that they have. And so far, I think they've been very well received. We also, on another note, have met with the unions, my union partners. It was actually nice to ask us to try to convene everybody together. So we now have monthly meetings with the unions to talk about diversity. We had our first one, I think, last week, and we'll be developing kind of a list of topics to tackle. But it was very well received, and certainly we can't continue to move the needle without our union partners. And so they've been very receptive and engaged in this process.
Thank you so much, Andy. Next slide. So with the Diversity University, and this is our new logo that I mentioned previously that the organization will see regarding any diversity training initiatives. I wanted to talk about the CCHL training, which includes all of our new hires and current employees that must have this training every year. The new hires are getting in as well as the current employees through our reorientation. For the This Is Home continued education, we have had approximately 600 employees that have been trained through this. We have had some great feedback. We're now in module 1. We will continue in March to start module 2. We're going to be going through the process of train the trainer program for This Is Home. So myself, Kelly Werford, and Donna Brown will be assisting in the training for This Is Home. Next slide. The Diversity and Inclusion Council, as I had mentioned, is broken up into 2 task forces. And we found this was important because one, with our council, we wanted to make sure that we were addressing the issues, addressing and getting the communication across to our organization. So one of our task force is our communication task force, and the purpose is that we provide information to our organization on the diversity efforts, our news, our resources. And one of the initiative or projects that we will be working on is providing a newsletter. So we want to get that out to the employees so they can see what's happening under the Office of Diversity and Inclusion. Our next slide. And then we have our Cultural Awareness Task Force. We felt that this was very important as this aims to create an environment that respects and appreciates cultural differences in the workplace. So we have some great goals and objectives that we're going to be working on, and we will be working together to communicate. And then we will come together as a council and vote on what's important and talk about the concerns under each to make sure that we're addressing any concerns, and also promotion. Next slide. Our diversity and employee engagement survey, again, it was open from October 19th to the 23rd of November. And that number was increased to 1,192 employees. So we were shy of 1,200. And we did have weekly prizes. So we really wanted to encourage our employees and promote the survey. So we gave out weekly prizes, and we will be doing a survey data review. Next slide. So with our internal promotion, we're again is really in promoting minority leadership promotions. So in the last couple of months, I wanted to just list the 4 employees internally who have been promoted. We have Chantal to Director of Nursing, Dana Clark to Unit Manager, Med-Surg, Chantrice Curran, Unit Manager, and Charles Presley to Staff Council. So we're very excited about that. Again, we're really working to be, and Tom always say, intentional in recognizing our minorities in the leadership promotion. Our next slide. So this is our service line. I won't go through it. I know time is short, but this is the services under the Office of Diversity and Inclusion, our contact information. We do have a confidential email that if employees would like to contact us, and our website is also shown in our phone number. So the Office of Diversity really wants to create a safe space for if any employees would like to come and speak with us in regards to any diversity issues or concerns. And our last slide, I believe. Yes, thank you. And is there any questions?
Yeah, Cindy, I've got 2. The first is, will you be able to provide the board with an assessment right across the board of where the demographics are by job classification?
Yes.
So when we see, so specifically, when we see our numbers, how many nurses are involved, and how many physicians are involved, and how many of our additional providers are involved, much less, all of the other ancillary service lines.
I know that with I can provide classification and job titles. Yes, I can. I'm going to ask Andy, as far as physicians, that information.
Yeah, we'll have to get that. We can get that information from, I work with Dr. Murray from the credentialing office to supply that.
Because it gets to thank you. It gets to my next question, which is, if you go back to those 2 slides where you showed the members of your 2 D&I committees.
Yes.
My initial observation is that we're light on doctors. I know there's one, I think there's one, as I recall the slide, there's one in each group. I'm just wondering, since they're so pivotal, whether we need a more in-depth representation from the physicians themselves? And it's a
Yeah.
question.
Well, let me make a comment about that. Your observation is correct. I will say though, like, from a physician standpoint, over the last couple of years, we have had certainly more minority physicians to join our medical staff. We have brought that also to the attention of UB, and they are also in the process of developing a task force around diversity, and have asked for our input there. So, I think we need to continue to monitor that and to engage them in order to make progress on the physician front.
Well, you would not be surprised to hear that I wouldn't wait for the university to do just about anything. This is on us. So if there's additional, and I would ask for Dr. Murray's input in this, if there are additional physicians that we need to put on these committees, certainly to drive it, then we ought to think about that.
Yeah, just a quick comment. I think as Cindy said, we've been very intentional in what we've been doing with regard to hiring individuals generally, and obviously making sure that we give everybody opportunity to advance in the organization and develop people. But to your point, John, I think the physician piece is probably, and it's not just ECMC, it's across the community, our weakest piece, and we need to be very intentional about the efforts that we're making in that regard. And I agree with you, we can't wait for anybody else to do it for us, but obviously have to work in partnership with the folks that contracts that we have with our university partners. But having said that, we do most of the recruitment in a lot of those areas anyway. So we have been trying very, very hard to source individuals and really recruit individuals. The pipeline, back to Andy's point, I think needs to be improved, especially, and I think the university is focused on that. And our hope is that we will have more candidates to be able to recruit. We are very happy to have a physician join us at Terrace View in a leadership role. So we just need to continue to be intentional, as my friend Bishop Badger had said to me when I first started this position. So.
Okay. Questions from the board?
John, I've got one quick question. I mean, it sounds like we do an awful lot of recruitment from UB, and I understand that it's close, but do we actively, pursue other medical colleges for their students and future doctors?
Go ahead, Andy.
Yeah, this is Andy. We do. As we've been trying to recruit, we've asked our recruiters to look at HBCUs like Meharry and others for opportunities. We've actually had some decent success with one of the members on that list, Dr. Yakuma, who was a primary care physician that we recruited, who grew up in Toronto. And he actually helped us recruit another minority person who would join us this summer in oncology. So, I think although sometimes it's a little bit difficult given the market here, we've had some success, and we'll continue to advertise in places like HBCUs, et cetera, historically Black colleges and universities, and other avenues of color.
Thank you, Andy.
Any other questions? Any
yeah,
other questions
just
for Cindy or Tom? Andy?
John, I have a question.
Please, Gino.
So I see that the numbers for Latinos are at 3.5%, and I didn't see anything on there as far as recruitment in the 14201 or 14213, which is the area where a lot of the Latinos live. So I was wondering if Andy and Cindy, if you had any kind of a plan to do recruitment in the Latino community, because I see that the numbers from 2019 to 2020 went down. There was 20, and then it went down to 18. So we're going in the wrong direction. And I wanted to know if you are thinking about putting a plan together to address that.
Yeah, this is Andy. We need to put a plan together. We've had some loose conversations, with some members more in the Latino community, but we do need to address putting a more concrete plan together. We have done some advertisements that I know the HR has done to hire people in those zip codes, but I'll have to get you a little bit more color on a direct plan on that.
Can you help us do that? I mean, are there things that we're missing, or can we, offline talk further about that? You make a great point.
I can. I could probably put some people together that represent a cross-section of the community. We can have some discussions on the best way to approach that.
That would be great. We would Cindy and I can work with you on that.
Yeah,
Okay,
that would be wonderful. Thank you.
you're welcome.
Great point, Gino. Thank you.
You're welcome.
Any other questions before we move on our agenda for Cindy or Andy or Tom? Just for everyone's edification, the meeting that we're talking about would be January 26th. So we give everybody enough time. That's our January board meeting. And the thought now is to meet at approximately 3 p.m. and go right into do the training for the board and go right into our regular board session. And, I'm going to suggest to you that if there was ever a meeting that we need everyone's presence at and participation in, it would be that. We have made a great point and to Cindy's efforts, committed to doing this. It is incumbent and indeed, I would argue, the responsibility of our board to participate in this training and demonstrate our leadership to the rest of the hospital community by going through this. So I'm going to suggest to you now that January 26th is a must-attend meeting, if we can put it that way, and would hope that we get 100% attendance. And with the caveat, of course, that we're going to be able to meet as a group. But even so, at this point, that's our plan.
Hey, John, I'd just
Yeah.
like to make a comment.
Sure.
Just want to say kudos to Tom and to his staff, especially where we're at in our society today with the issues that we're facing. This didn't start, this year. This has been an ongoing, as Tom said, and when he said intentional, I was so happy to hear that, because I think that's what you have to be in order to really bend the curve. And I just want to thank Cindy for the hard work that she's done. And I'm just really proud to be a part of ECMC and just to see all of the things that are happening to make this the great hospital that it is. And I think this is just another part of why this hospital is such a jewel in our community. So once again, to Tom and to his staff, kudos for what you guys are doing. You were ahead of the curve before this really became a national issue. You were already dealing with it. And I think that speaks volumes about the leadership and what ECMC represents. So thank you.
Thank you.
Thank
Thank
you,
you for saying that, Bishop. And even more to the point about having our board involved. And I think it's critical that we walk the talk in this case. And so if you would please put January 26th on your calendars, and we'll continue to work with Cindy and be sure that we are in every instance doing whatever we can to be sure that this diversity and inclusion project is successful.
Thank you so much. And thank you, Mr. Dandies. Thank you, Tom and the board. And thank you again. And everyone have a wonderful holiday and stay safe. Thank you.
Thank you, Cindy. Tom, anything else before we move on?
No, just I want to thank the board for your support of all of our efforts and your commitment to being part of it, because as John said, your direct involvement and support goes noticed by the ECMC family. So we appreciate it.
Thank you. Thank you, Tom. And you will follow up with Gino on his offer.
Yep. Yeah, I know we had some plans pre-COVID to get involved in some events and things. I know Joe was involved in that in March, and so we just need to fire that back up again. So.
Great. Thank you.
Thank you.
Okay, on to our resolutions. The first one with regard to 2282 Elmwood Avenue, Councilor Calucci.
Good afternoon, Mr. Dandies and everyone else on the line. I hope you can hear me well. Can, right?
Yes.
Great. Back.
Yeah, we can hear the 85 degrees and sunny that you're in.
Yeah, okay. About 8 years ago, this board approved the purchase of 2282 Elmwood Avenue by the corporation. It was used up until a little over a year ago as a location for a chemical dependency clinic and outpatient services that we delivered from that location. We moved that program from 2282 Elmwood Avenue to 2005 Sheridan Drive, and we lease space on Sheridan Drive now. The reason for moving the program predominantly is that the condition of 2282 Elmwood Avenue has deteriorated tremendously. So much so that it would be not an embellishment to suggest to you that the snow that falls outside doesn't stay outside. It actually comes inside the building when it snows. And as a result of that, you might guess that the building itself is no longer up to code and is no longer suitable for healthcare services. So as a result of that, after moving the chemical dependency program, a decision was made on the administrative side that we would dispose of that property. Those of you who are students of municipal law and procurement know that we have certain obligations that we must undertake in order to dispose of property of this nature. We did those things. We sent public notice out that we were interested in selling the property. We obtained an independent appraisal, and we obtained more than one bid in response to all of that. The bid that we received of $190,000 to purchase the property is consistent with the appraisal, which came back right about at that number. And we now are seeking the board's approval of the sale of this real property in that amount to the highest bidder.
Questions for Tony?
I'll move it.
I'll second it.
Well, hold on. Any questions before we go to a motion? Okay, the motion has been made and seconded. Further conversation? All those in favor of approving the motion for the sale of 2282, please signify by saying aye.
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 And contrary? That motion carries. Thank you, Tony. Dr. Flynn and/or Dr. Murray on medical dental staff meeting minutes?
John, Dr. Flynn is in surgery, so he's asked me to take up the mantle here.
Sure.
I have two items. First of all, the Credentials Committee met on the 5th of November. The minutes are available in your package and were approved yesterday by the Medical Executive Committee. There were 14 new appointments, which involved 8 physicians, 6 in internal medicine, 1 neurology, and 1 orthopedic surgeon. In addition, there were 6 allied health professionals. We had 3 resignations. None of those were of any operational significance, and there were 30 reappointments. I'd also like to mention that the committee recommended and the executive committee agreed to confer emeritus status on 3 physicians who have served the hospital in the past and are now retired. One is Dr. Daniel Schaefer of ophthalmology. The second was Dr. Gregory Bennett, a neurosurgeon. And the final one was Dr. Kevin Pranikoff of urology, who, as many of you will know, actually served on this board. So that's the Credentials Committee meeting. I will obviously need a motion to receive and file those minutes. And then I have a Chief of Service announcement.
So the the resolution then will include the appointments of the emeritus physicians as well?
Yes, it will.
Okay. Is there a motion to, I mean, by the way, Brian, if we could, at some point, when we do these, have a D&I review of these reappointments, and just so that we've got an ongoing record of how we're doing. This might be an interesting statistic for us or metric to look at.
Okay, okay, we can work on that.
We can do that. Anyway, is there a motion in support of the medical dental staff meeting minutes?
So moved.
Motion by Mike Seaman.
Mike Seaman, is there a second?
I'll second.
Thank you. Further discussion?
This is Sharon. I'd like to know, do we give the retiring doctors, particularly Dr. Pranikoff, who served on our board for a number of years, do we give him any kind of memento, a certificate or anything of that nature?
The medical staff recognized him at the time of his retirement. We actually had a reception and did grant him that when he retired from the medical staff.
Yeah, did we not do that in the overflow room?
I believe there was.
I don't recall Dr. Pranikoff being there.
No, he was there with his family, I believe.
Okay, that's all I wanted, just so long as we recognize him for his participation in volunteer efforts.
Well, we can certainly double check, Sharon, but that's a good point.
Thank you,
Motion has
Sharon.
been made and seconded. If there was no further discussion, everyone in favor, please signify by saying aye.
Aye.
And opposed. That motion carries as well. Thanks, everyone.
Also, John, I was
Yes.
notified earlier this month by Dr. Vanessa Barnaby that she was requesting to step down as the Chief of Service for OBGYN effective next Monday. And after discussions with her and the new chair, they have proposed that Dr. Suzanne Griffith succeed her in the position of Chief of Service. Dr. Griffith is a graduate of the State University of New York Upstate Medical University, where she also completed a residency. Following her residency, she was actually hired by UBMD. She has practiced here at ECMC, both in the community clinic and provides ongoing consultative services here. So she's a physical presence. I've met with Dr. Griffith, and I certainly endorse the recommendation and would request that the board formally appoint her as the Chief of Service for OBGYN effective November 30th.
Thank you, Brian. Is there a motion in support of this appointment?
So moved.
Motion is
Second.
moved. And Katie Grimm and seconded. Further discussion or questions for Dr. Murray? All in favor of the motion, please signify by saying aye.
Aye.
And to the contrary, that motion carries as well.
I thank the board for their indulgence. Thank you.
Thank you, Dr. Murray. Anything else on this subject?
No,
I guess
no.
not. Okay, thank you. Tom, Dr. Quattrochi.
Okay, thank you, Mr. Chairman. Jeffrey, you can go to the next slide. Okay, so obviously wanted to start out with COVID efforts and where we're at. To date, we've had 372 COVID patients. Our average length of stay is 7.8, which is noteworthy because our length of stay at our height of the pandemic was 3 times that. So we are doing a better job of treating these patients earlier. I think people are getting in here earlier, which also helps, and patients are somewhat younger. So that's obviously helping the length of stay also. So we're almost discharging as many people as we are seeing. Currently in-house, we have 28 COVID patients. That's about double of where we were midweek last week. And we have 3 patients who are vented. We're doing fine from a bed capacity standpoint and an ICU standpoint. Actually, most of our ICU patients are obviously not COVID patients. And we've actually had to take some transfers from the community. So we're in good shape from a bed capacity and a staffing capacity, which would be our two main concerns moving forward. Patients under investigation right now, we have 0, and we've had 75,000 negative tests to date. We've got about 40 employees out right now due to COVID, and 20 more under testing right now. So we are seeing a little bit of an uptick in staffing with regard to COVID, and we have some individuals out because of childcare. So next slide. So
Tom,
some of the
just
things.
Tom, just as a question,
Yep.
and I don't want to preempt anything that you might be prepared to say, but can you give us what your, between you and Andy, what your thoughts are relative to, our pending red status and, what we're up against?
Yeah, I think, from our standpoint, it won't be much different than what we're doing already, which I'll talk about in a sec. But other than the fact that we just need to watch our beds and our staffing to determine whether we need to suspend elective surgery, inpatient elective surgery. As you know, as a trauma center, we don't, and where 78% of the admissions come to the ED, we don't have a ton of elective inpatient surgery, maybe 20 patients a day, somewhere in that vicinity, which is 2 units. But we're gonna continue to monitor that. We are kind of having a pause on inpatient elective surgery anyway, because between Wednesday of tomorrow of this week and Sunday, we have very, very few elective inpatients anyway. I think we have 2. So we're in effect kind of having a little bit of a pause over the next 4 days anyway. And then we're continuing to monitor it. But that's, pretty much the initiatives which I'm going to talk about here, John, are going to stay in place, and that we've had now our COVID designated units. And we've had to expand those. We have our visitor restriction, which obviously means no visitors other than compassionate care or patients who are in crisis. We've started our work from home initiative again. And we have,
I'm on a call.
oh, Donna, your phone's not on mute.
Oh, I'm sorry.
That's okay. And then working from home. So we have had about 350 people working from home last time we did this. We have about half that working from home now. Basically, some people are wanting to work from home, some people don't. That may increase. We're obviously offering that as an option to many people. We're supporting our frontline team. Obviously mental health is a big piece of this, as we all have experienced through the isolation of COVID, and making sure that we are supporting our frontline team, rounding with the AP, meditation apps, fitness classes. Karen's really been doing a lot to make sure she's staying in touch with the mental health of our frontline team, and has been doing an unbelievable job in that regard. Student access is going to be reduced significantly across the institution, has already. And then our ER, the good news about the new construction is we do have an area we can actually do this inside rather than a tent, but we're triaging individuals at a different place than our waiting room, so that individuals don't get into the ER. We reduce the traffic in our emergency room, and obviously restrict visitors from going back in the emergency room. So before I get to some of the quality statistics, are there any questions with regard to COVID?
Tom, would you share with everyone, to the degree that you're able, some of the cross-community conversations that you've been having, particularly with the county executive and with Kaleida, and how we're working amongst and between all those entities, please?
Yep. So we have a weekly call now with county executive, really looking at bed capacity and ICU capacity. I think the Catholic suspended some surgery, inpatient surgeries, and also closed one of their St. Joe's emergency department. It sounded like basically because of staff, not necessarily beds and the amount of staff that they have out. We don't feel we're in that position as to date, either does Kaleida, but we are coordinating with Kaleida. We did transfer a couple ICU patients from Buffalo General to ECMC over the past couple days to assist. But we are coordinating efforts, obviously, with our partners at Kaleida, but having regular meetings with the county executive to make sure he's informed of our capacity and ability. Sometimes the numbers that they're getting doesn't necessarily reflect what's actually going on. For instance, we can increase our beds by 48 if we really needed to in a surge situation. So that wouldn't show up on the reports that the county executive necessarily or his team would see. So the communication's been good, and again, continuing to work with the hospital systems in the community.
Tom, this
Thank
is
you.
Sharon.
Thank you,
Well,
Tom.
if the governor moves us to a red zone, would that mean automatically that you would have to go to non-elective surgery?
I do not believe, Sharon, that that's in those regulations, but we've talked as a team whether we would have to do that at that point. Again, from an operational standpoint, we can turn that off very quickly. Our inpatient surgeries are frankly mostly orthopedics, elective, and those patients, have 2 days length of stay. So if we decided, today, for example, if we didn't have Thanksgiving and everything else, by Friday, those patients would be pretty much out of the building. And so we can react very quickly. But to answer your question is that would be a factor in our decision-making process, but I do not believe that it's a requirement.
Okay, thank you.
Yep. Any other questions regarding COVID? Okay. Just with regard to our quality and journey to zero, I wanted to point out that we're continuing to monitor our hospital-acquired conditions, and we have seen an uptick in some of those in our central line and also our catheter-associated. I did that backwards. Catheter-associated is first there, and then central line second. That we have had a little bit of an uptick, and we are doing pretty well with catheter-associated urinary tract infections. We have 11, and last year we had 14. With our central lines, infections were at par where we were last year, but obviously 3 of those were COVID patients. So we had a lot of individuals on vents before. So I just wanted to point those hospital-acquired conditions out to the board. Next slide. So I'm not going to read through this, just some efforts that we've been doing in our journey to continue to improve the quality here at ECMC, and we actually won a poster Pathways to Excellence. As you know, we obtained that designation, but we had a poster day at Buffalo UB's Research Day and actually won that. So we're very proud of Joanne Wolf and Nicole Durenda for that. We also just completed our survey, our nursing survey, so our NDNQI survey. So Karen, I'm just going to ask you to take 5 seconds and talk about that because we just got the results, and Karen was very excited because the results were very positive. And she can talk about how many nurses took it and what this really means. So go ahead, Karen. And Karen, you might be on mute. There you go.
Every year the nurses take the NDNQI survey, and the survey, the aim of it is to improve healthcare safety and quality. So this year I was a little concerned because it was in the middle of the pandemic. We had to alter even the month that the nurses took it. There was a lot of change with the opening and closing of different units and all the change that happened not only here, but in society. And we had to just rely on virtual announcements versus really doing full court press and having everyone take it. But the results came in November, literally last Friday, and over half the nurses did take the survey. It is an anonymous survey, so I love it because people can say whatever they want to say in terms of structure, process, outcomes in the nursing department, and then we take their feedback and we process improve so that we could get better and stronger. And I have to say, the results were really very, very good. Many areas are very positive. And I'll only read off just a couple. The teamwork between RN and the physicians, very high this year. The RNs between themselves and their frontline team and staff, all are in the 5th category, which is almost to the top. The support that they feel the hospital gives towards them receiving a bachelor's or master's degree. We made a 20-point gain between 2016 and 2020. So I'm still reading it all and digesting it, and then I will share it with all the nurses, with all the management team, so that anything that they do feel that they would like to see move differently or feel strongly that we should move quicker, we will process and improve to that. Thank you, Tom.
Thanks, Karen. And maybe we can bring those results when we analyze them more back to the board here in January. So that'd be great. Okay, next slide. So we, as you know, have our progressive huddle system where we make sure that the units have huddles during the week. And we've now expanded that to the weekend. So Donna Jones and Karen and others have done a great job of making sure that we continue to include our weekend and night staff with regard to our huddle system, our huddle process. And we've received a grant here that you can see. And also we're holding national certification classes for med-surg nursing critical care. Go ahead, next slide. We're continuing on our journey to zero harm as we talk about high reliability, and we actually are now celebrating areas which have zero harm. And we had different areas, we call them our zero heroes, right, Karen? Is that right?
Yes, yes.
Zero heroes. And we have those across the organization, so we've been doing a lot of celebrating around that. And we're having the Professional Nurses Association of Western New York actually is virtual this year, so I just want to point out the individuals who received those awards. Next slide. Patient experience, we have a little bit of a downtick in patient experience. This is across the country. This is not just ECMC because of COVID, interestingly enough. So we've continued to maintain our scores at a pretty high level. Obviously for a safety net hospital, but we'll continue to monitor these patient experience scores moving forward. Next slide. Culture. Next slide. So we are very happy to have another significant donation from Tim Hortons for the campaign, $135,000. We actually, I think to date are at almost $400,000. So just very pleased that the community continues to support us through the Smile Cookie campaign. Next slide. Got another check through YRK. And another fundraiser we did. Next slide. And we're continuing just to build morale. We had a Halloween group costume competition. A lot of people got involved, and we also are doing Bill's garb on Fridays to make sure we continue to just keep everybody focused on the positive, especially when the Bills win. Culture, also Thanksgiving gift cards, Thanksgiving dinner. We actually had Russell and Nick Patello from Asterio come today to drop off dinners for our frontline workers, for those who are working Thanksgiving Day. We do the pies every year from the executive team and the foundation. We have an ECMC virtual school support line, so IT actually is helping our parents here who are having any issues with their children with regard to online school, and we've offered those services from IT. And our annual giving campaign, we have 6 weeks left on our annual giving campaign. We're actually a little bit ahead of where we were at this point last year, but I just wanted to give you the statistics on the annual giving. Next slide. Thank you to the medical dental staff. I wish Dr. Flynn was on the phone here. They did lunch for the entire building as they do every year, and obviously they had to do that virtually. They did a video for all the employees. And we have a bunch of weeks that we're obviously supporting. And again, Karen referenced the support for advancement of professionals in the organization, whether they're getting an LPN or an RN. And we had 79 participants that the foundation supported this year. And I believe it's $1,500, Karen, now that we give? Just
about, yes.
Yep.
They could get anywhere between 1,000 and 1,500.
So kudos to the foundation board for all their support and making sure that we can advance. And we got wonderful letters from individuals who are trying to advance their career and move into their LPN position or an RN position. So it's really meaningful to them. Next slide. We have a couple new physicians who are going to be doing surgery here, Dr. Keely Boyle and Dr. Scott Nodzo. They are UB orthopedic physicians who will be doing total joints here at ECMC starting in December. So I want to make sure we point that out. Next slide. October key statistics. So we're continuing to see very high inpatient volumes and a decrease in, as you can see, observation. Our surgeries continue to be down a little bit. Again, Some of that's because of the movement from inpatient joints to outpatient joints. Some of that's related to COVID. Some of that's related to the fact we had a couple high volume surgeons out this month, but continuing again to see the high inpatient volumes. So, and reduction in length of stay, which is really incredible considering many of the patients that we're seeing are coming through the emergency department, not necessarily surgery patients. So Karen and her team and Dr. Murray are doing a fantastic job around that. Next slide. Okay, I'll turn it over to John for finance. John?
All right, thanks, Tom. So let me start first by saying the trends that you'll see that you just saw on the last slide are not that different from the prior month's trends. So we're seeing good volume, strong volume. However, what we're seeing in the type of volume is not the high revenue, high margin volume, and you can see that on this slide. But before I get into the operations, which I'll focus some time on, it's important to note that when you look at this first line, you may recall over the last couple of discussions we've had, I talked about the potential for a very large additional non-cash actuarial pension expense adjustment. We've been analyzing that, and I'll talk more about it on when I get to it in a few moments, but we've been analyzing that and looking through that. But what you'll see this month, in the month of October, is that we did record a significant component of that, which amounts to about 10 months worth. It's about 30 million of additional expense. Again, non-cash, it's an actuarial adjustment. And so when we get into the information upcoming, you'll see that we've separated that out. So what we did want to really focus on, though, is some of the operations. And this dashboard, as you recall from last month, we started doing last month just to give us a sense, give the board a sense of kind of what we look at, what the drivers are. So again, discharges up about 2.5%, managing the length of stay, managing the FTEs. Our cash is stable, but we're seeing an 8.2% drop in total surgeries, which again drove down our severity index of case mix, which drives down revenue. So really on the next slide, you can see that, and it's a little busy, I know, but we've done this because we wanted to separate out the pension adjustment from all of the other operations and how we've been looking at it. So just in looking at this and trying to stay consistent with how we've talked about this the last several months, you can see here our loss before the pension, loss from operations, is about $4.7 million. And when you offset that with the CARES Act funding relief, which is a couple lines below, of about 2.7, our loss for the month was roughly $2 million, which is really driven by the revenue that we've just discussed, but also we're continuing to incur COVID-related costs, preparedness costs, PPE, and it's some additional staffing. Again, that $2 million is before pension. And so just as a quick reminder, I know I've talked about this, but when New York State values their retirement plan system, which many of our employees are in and former employees are in, they value that at the fiscal year end, which is March 31st. March 31st was, of course, smack dab in the middle of the depressed markets, both in market value, but also within the interest rates. Obviously, that's come back, but their valuation date is a hard and fast date. So it has an impact on paper. We believe some of this may be temporary, just given where the markets have come back to, but we won't know that until next March. So when we evaluated it, really understood it, looked at the GASB requirements, we felt it prudent to record 10 months worth in October, so that our year-to-date figures on the next slide, Jeffra, would reflect that 10 months of pension expense, and we'll record the next 2 months worth over November and December. But again, staying consistent with our methodology and how we've been looking at our financial performance, if you look at our loss here of $88 million before any CARES Act relief and offset that with the 46.8 down below, we're roughly around $41.5 million of an operating loss before the pension, but after the funding relief. And that's right in line with where we had been projecting early on in the pandemic of where we might end the year absent any further relief. And of course, when you add in the pension expense, which is non-cash, the numbers do get a bit staggering for all of us on the phone. We're not used to seeing these kinds of figures, but it is a reality. And we do this in this presentation this way because the GASB forces us to record the CARES Act funding as non-operating, but the pension expense is an operating expense. And that takes me to where we typically go after that, and that's a snapshot of our COVID costs and the impact on the organization since the beginning, and that's really March 15th. And we continue to track this. We continue to track it for all the reasons that we've talked about before, whether it's FEMA or approving and reporting out through HHS for their provider relief funds in order to support those. But you can see here that we've almost reached 80 million as of 10/31. Again, this is a snapshot, so this is continuing to grow, primarily continuing mainly in the supply category, services for cleaning, and then certainly in the screeners and staff. Lost revenue, although we still have some, at least prior to October 31st, that really, given our volume, had come back and really slowed down in terms of lost revenue. This slide, of course, does not include the additional expense related to pension, although it is driven by the COVID pandemic, but we're trying to keep this calculation and our tracking mechanisms free of that non-cash expense for now, but we know it's there. Just a couple.
John, are you anticipating that the potential lost revenue could increase in this next month or so if we need to do something relative to what we euphemistically refer to as elective surgeries?
Right. Sure, it could. The way we calculate that is simply looking at our run rate of our revenue, especially those cases pre-COVID, and calculating it and just doing a match. So if there is any change there, then that could grow. A couple of updates here. I won't spend a lot of time here, but because there's not much new on this page, but the first bullet that I will talk about is phase 3, and that's the latest application process for additional funding relief. That application went in on November 5th. We have not heard anything yet from HHS on that, but do expect to hear within the several weeks. We do believe they're working very hard to try to figure out how much they might be giving out to providers. And again, there's 2 tranches of that, but more to come on that as we get into the tail end of this year.
What would you think that number might be for us? I know it's speculative at this point, but what would you be hoping for?
Honestly, it's almost impossible to estimate because of the way they're doing this calculation, John. The first phase of it is to get money to those providers who haven't yet received 2% of their net revenue. We have achieved our 2% payment of at least our 2018 net revenue. If they update that calculation to 2019, that could be a few $100,000. But other than that, we don't know what's left because they'll take what's left and potentially provide it as an add-on payment to those organizations that are still that operationally well behind as it compared to prior year. So I wish I could give you a number. I wish I had a number, but I don't.
Okay, thank you.
Yep. The last 2 items on that slide, just as a quick update. These are 2 similar to the pension, but not in dollars, at least in the same size. The retiree health expense we value at year end, and the public nursing home payments that we get for our upper payment limit, we already know that will be reduced. How much, we're still waiting for the final number, but those are 2 other items that we would expect to see as unfavorable expense items or lower revenue. With that, John, I'll stop and ask if there are any questions that we can answer.
Questions for John? Just one from my perspective on the $30 million in the pension. John, is that a balance sheet item? Why does it appear in our P&L?
Because the way that the pension accounting works under GASB is that the actuarial changes run through your P&L, and they usually amortize those over a 5-year period. So in a case like this year, where the market was really depressed, the majority of the lost market, if you will, market value, has to get amortized into your pension liability over a 5-year period, beginning with the year you're in. That's different from GASB is a bit different than the FASB rules, which the non-governmental areas take that through the balance sheet, whereas here that additional liability runs through our P&L over a 5-year period.
So without beating a dead horse, if it's payable over or it's amortized over 5 years, why is the full amount applied to one fiscal year?
That amount is actuarially, as they calculated, at 1/5 of the difference that's allocated to us. But what we're anticipating is, given the market, that would essentially turn itself around because next year's valuation would be much higher.
Got it. Okay, thank you. Any other questions for John? Thank you, John.
Welcome.
Committee reports, finance, Mike Seaman?
Hey, John, I'm sorry, I was unable to attend the Finance Committee meeting this month. I would defer any questions if Darby has any or anything to add, because I wasn't able to attend the meeting.
And Michael, let me say on behalf of our board, my condolences once again on the passing of your brother.
I appreciate that. Thanks, John.
Those are, well, our condolences. Questions with regard to Darby or anything on the Finance Committee? Mr. Bennett, Buildings and Grounds. Okay, I guess we've lost Mr. Bennett. Bishop Badger on Human Resources.
John, the presentation that was done by Diversity was pretty much what we had as far as HR, unless Joe has something else.
No,
John, I think Ron Bennett was available.
Oh, well, let's finish up on the HR. Anything, Joe Gilia, anything further to report then?
No, thank you, John.
Okay, thank you. Mr. Bennett.
Well, as I started, we had a very short meeting after months and months of the major projects. It seems nice to see how we're coming together. Major thing was the parking lot at the ED. It really is nice, and it's going to be very convenient for the patients and their loved ones. And basically everything else is coming along. The windows, of course, are going to be a continuing process. Other than that, they work hard, Mike and Andy and Jim. Great organization.
Thank you, Ron. Questions for Ron Bennett? Mike Hofford on QI.
Hello, John, and board members. The report is in your minutes. I invite you to check it out there. It is quite lengthy, as the meetings are, but unless anyone has any questions, that'll be it.
Questions for Mike? Okay, let's take, thank you. Let's take 30 seconds and we'll go into executive session.
Okay.
Thank you. We are back in public section. I have one last item before I wish everyone a very happy and safe Thanksgiving and a wonderful holiday. I had sent a note out last week asking for everyone's participation and support for our annual fund. I will hope that by the time we meet next, we will have 100% participation. It is critical, and we need to make sure that we get that done. So if you haven't already, Sue has got, there are 6 or 7 different ways that you can join the annual fund by phone, by text, by email, by credit card, by check, by cash. But it is imperative that we all support the annual fund. And as Tom said earlier in the meeting, our hospital colleagues, the staff and employees of the hospital are doing a great job. And thank you, Sue Gonzalez, for getting all that done. So please, if you would, make sure that you complete those requests. For the good of the order, is there anything else that we need to talk about at this time? Once again, everyone, please stay safe. Have a great Thanksgiving, and we stand adjourned.
All right, happy Thanksgiving.
Have a good holiday, everyone.
Thanksgiving, everybody. Happy Thanksgiving.